So welcome to the session on the efficient and equitable public health systems. It's hosted by myself, Sarah Hill, and my colleague, Christina Fernandez-Garcia, who will be presenting after me. Hopefully, if you just saw the videos before, you will have seen Penny Breeze introduce the efficient and equitable public health systems theme. So you will hopefully know a little bit about what we're talking about today. Just a bit of housekeeping before we get going. Hopefully those of you who were in the sessions yesterday will already be quite familiar with the chat and the polls function. But in case you're not, on the right-hand side of your screen, there should be a little chat box where you can put in any questions and comments. And there's also a little tab that says polls. So if you can click on the polls tab, we will be having some polls going on throughout the session today, which would really value your input in. There should be one live already that's asking about what you do. So if you wouldn't mind entering that poll, telling us a little bit, whether you're a researcher, whether you're a public health practitioner or a PhD student or something else, that would be really useful for us to know who's in this session and what sort of mix of people we've got at the session. So a little bit of background. As Penny already introduced this morning, Workshop 1 is a series of workshops aiming to develop best practice guidance for the measurement of efficiency, the incorporation of equity, and the use of health systems modelling within public health research. These workshops have been developed as part of the School of Public Health Research and funded by the NIHR. And we've got quite a broad research team who are taking over these workshops. I'm not going to list everyone's names, but you can see that we've got researchers from quite a broad range of the UK. We're dotted all over with some really good experienced researchers in there. So today's session, we're going to be focusing on just the efficiency and equity components of the workshops. We're not going to be focusing on the health systems modelling today.
Sorry, Sarah, I'm going to jump in because people can't see the poll. So I don't know if Emily and Katie can have a look at that.
Yeah, kids. Yeah, hopefully, the admin team can get that sorted. There should be a poll there asking.
I think it's sorted now. Yeah, thank you.
No worries, thank you. So today I'm leading the efficiency workshops and Christina's leading the equity workshops. So I will be talking to you a bit today about the efficiency workshop, about what our first workshop has found, and also getting a few of your opinions and your views on on efficiency. And Christina will be doing the same for the equity. Just before we get started, I do want to do a bit of a shameless plug for our next workshops. Christina and I are hosting 2 workshops in July that are specifically for public health professionals, practitioners. So anyone who works in a professional public health role, not a researcher, but someone who's actually a public health professional. We'd love you to come join us at our workshops in July. One will be on efficiency and one will be on equity, and they'll be expanding in much greater detail a bit what we're talking about today. We will be advertising this through SVHR with further details, but just wanted to get a few save the dates. So if you are a public health practitioner and you're in this session today, please make a note of the dates. And if you have if you know of any ways that we can spread the word about these workshops, please do pop something in the chat and we can get back to you. That'd be really useful. So to start with, what do you think of when we talk about efficiency in public health? Within health economics, we have quite a sort of solid definition or definitions of what we mean by efficiency, but what is considered as efficiency can change depending on the context and who's thinking about it. And whilst it's really important to the work that we as health economists do, that's what we're striving to look for, we don't necessarily know if what we think of as efficiency aligns with what everyone else thinks of as efficiency. So if I can direct you to poll number 1, hopefully Katie can make that go live. I'm actually going to stop sharing my screen for a second so that I can see the poll, because I'd really like to see the answers. So if you can all have a look at poll number 1, and I know there is there's quite a few things there, so I'll give you a moment to have a look through. And if you can please select the one definition that you think most aligns with what you think of as efficiency. I had hoped to be able to allow people to do more than one option, but unfortunately that wasn't possible. So if you think there's more than one, just pick the one that you think most aligns with your interpretation of efficiency. Katie, can we get it so that the results of the poll come up? Or can we not see that? Christina, can you see any results on the poll? No. Katie, any help?
I don't know if one of the participants can perhaps tell us if they can access the polls and vote, because we can see.
You can see the results after we've selected.
Okay, we're not able to see. Okay, maybe we have to vote as well, Sarah.
Oh,
that's probably why.
Okay. If I put one. Okay, yes. Okay, so we have to vote as well in order to see the results. Okay, there we go. Okay, so okay, still coming in nice, great. So we're getting the majority of getting the most health for fewest resources and choosing services that generate the most health. So, but also a few for social welfare as well. So that's really interesting. I think this is possibly showing the fact that most of the people here are academics and researchers, and we actually don't have any public health practitioners in this session, or if they are, they haven't told us that they're here. So that's really interesting. Thank you very much. I'm going to share my screen again. Okay. Is that back up again?
Yeah.
Thanks, Christina. Okay, so why are we interested in efficiency in public health? So economic evaluation is one of the things that we do as health economists, and we use this to help inform resource allocation decisions by looking at the efficiency of new technologies and programs. It's not the only thing we do, but it is one of the core things we do, and it obviously is whether we consider something efficient is highly dependent on what outcome measure we are using to measure efficiency. And within health economics, a lot of economic evaluation originated coming out of the sort of health technology arena, where we were looking at new drugs and new treatments. And in that arena, the obvious measure of efficiency is health. How much health are we getting from what we're putting in? However, we know that public health is complex, and maximizing health might not be sufficient. This might not be capturing everything that is considered important when someone is thinking about implementing a public health program. So we want to help develop guidance around conducting economic evaluations of public health interventions, because the literature on this is a lot more sparse than for healthcare technologies. There's certainly not as much solid guidance on how we should be conducting economic evaluations, what outcomes we should be measuring, and what we should be considering when we're thinking about maximizing efficiency in the public health sector. So that was the aim of this particular set of workshops. Ostensibly, we're producing guidance for health economists and researchers, but as public health practitioners are the end users of this information, we really want to involve them in the development of this guidance to make sure that what we're producing is actually going to be useful for the end users. Otherwise, there's no point in us doing the evaluations in the first place. So I'll give you a quick overview of the first workshop we conducted, the first efficiency workshop. This was with other health economists, so academics and researchers, and we just wanted to discuss what everyone is aware of in terms of current literature in the field around measuring efficiency in public health, and also identifying what we think should be in this document and what gaps there are still in our knowledge, because we are the first ones to say that we don't know everything. There are still things that we research on. So we will, some of the highlights from the first workshop we came up with was that there needs to be a shared understanding of efficiency between those conducting evaluations and those receiving the end product. And I think this closely aligns with what I was talking about before in terms of making sure that the evaluations that we conduct are actually fit for purpose at the end of the day and actually are able to help inform decisions from those working in public health, deciding what programs and what policies they want to implement. And in order for our evaluations to be useful, we need to make sure that what we consider as efficiency is the same as what the end users are thinking of in terms of efficiency, because if those two don't align, then our work ultimately will be limited in its use. Another thing that came up was that there's unlikely to be a one-size-fits-all approach to measuring efficiency. Public health is very broad, and there may not just be one outcome measure that we should be looking at for every single intervention. We will probably need to be flexible in our approaches, but it's still going to be important to have guidance that will help determine, in which situations do we take which approach, and still having some guidance on how to make those decisions. And also, we need to communicate with stakeholders at the beginning to identify the best outcome measure for the evaluation. So kind of following on from those two earlier points, finding out, actually having discussions with the end users, with those working in public health, those commissioning the services, identifying what's the best outcome measure going to be for this particular evaluation. But discussing that within the confines of what's possible, because there are certain outcomes that we can't measure or we can't measure very well. And so it can be a bit of a back and forth in terms of we can discuss what we think might be appropriate and what we could measure, and just checking with the stakeholders whether that is something that would be useful for them, and if not, having a discussion about what else we might be able to do instead. And also determining the purpose of the evaluation, because there are different types of efficiency, and the way that we measure it will depend on what the approach is. If you have two interventions both aimed at improving sexual health, you might want to know which one of those two to fund, and so you might be looking at a certain type of efficiency, which is seeing which one of those interventions or services will produce the most outcome for the least resources, which is quite a different question to if you have a range of services you want to fund with your budget and you're not sure which ones to fund. That's a different type of question. So we want to be sure that we're measuring efficiency in the right approach to help you answer your questions. As I said, we did acknowledge that there are gaps in our knowledge. There are things that we don't yet know fully that we would like to know to be able to further our evaluations. Some of those were very economic evaluation specific, to do with the sorts of time horizons we should be using, exactly what outcome measures we should be using. Some of those were broader public health questions to do with what public health practitioners want from us, and how other sectors consider health and well-being in their evaluations. And there was also a number of gaps that kind of crossed both of these questions. So if I can now direct you to poll number 2, here I've selected a number of the gaps in our knowledge that came out of the first workshop, and I'd really like you to have a read through of those. I know I'll give you a minute to have a read through and select the ones that you think are, the one that you think is most important for us to be focusing research on going forward. Again, I'm going to stop sharing so I can actually have a look at the poll. So I said there's a few there. Sorry, they're a little bit wordy, so I'll give you a moment to read through those. But if you can click on the one that you think is the most important for us to focus our efforts on going forward. I'm just going to click so I can see. Okay. Only 2 votes so far. I'll give people a few minutes to have a look through that because there is a little bit to take in there. Okay, great. We've got some votes coming in. So far, it's looking like we have quite a majority thinking that asking questions on finding out how to cost interventions and attribute outcomes is most important. There's quite a few coming in. Okay, great. So continue looking at that. Hopefully the next poll will be a bit easier because you won't need to read everything again. You've got exactly the same options, but this time I'd like to know which of those you think is the least important. So what should we perhaps divert attention away from? Not necessarily away from, but what is least important, do you think, right now to us in terms of the things that we're unsure about? I think these polls are going to be live for the entirety of the session. So if any of you would like to come back to it at the end or any points, then feel free to continue to select your options. Those should be available for the whole session. Just share my screen again. Okay, we've done poll 3. So the last bit of my session, I really wanted to have a bit of a discussion. I appreciate with the way that the session's hosted, we can't really have a discussion face to face. But if you can use the chat function, I'd really like you to suggest anything else that you think is relevant to consider when making commissioning or funding decisions for public health interventions besides efficiency. I'm aware I actually don't think there are any public health practitioners in this session, unfortunately, so we're not going to be able to get their opinions directly towards this. But if you're a public health researcher, have worked with public health closely, and have any suggestions with how you think, what you think would be relevant for them to consider, then please pop that in the chat. Again, I'll stop sharing my screen so I can actually see what's coming up, but I'd love to hear your opinions and have a bit of a one-way discussion on the results of that. Yes, Luke. If you scroll the polls, if you keep scrolling down, they should appear. So if anyone would like to put anything in the chat in terms of things that they think are important besides efficiency when we want to be making decisions, or when public health commissioners are making decisions about what interventions to fund, if you could pop that in the chat, that would be really useful. We could potentially get some sort of discussion going. Thank you for everyone for voting, by the way. There seems to be plenty of votes coming in for those, so hopefully we'll be able to look through this properly later. Peter van der Graaf says, what counts as evidence for who when measuring efficiency? Commissioners and public health members might have different ideas about what measures are relevant and meaningful. Yeah, completely. This is part of the complexity of public health that we really, and I think this comes down to why we need to be having discussions with public health stakeholders about what outcomes are actually going to be relevant and what counts as evidence as well. Yeah, I think 100%. Affordability. Yeah, maybe levels. I think affordability as well. That's certainly something that popped up from Professor Whitty yesterday, that the economic arguments are really important because everything has to go through the Treasury, at least at the higher level, perhaps not in local public health, but yeah, affordability, there needs to be really good arguments for why something is going to be important, have an impact in order to get someone to spend money on it. Levels of need, providing support for most vulnerable. Thank you, Sarah, definitely. John Frank saying, help prioritise as many possible health economic appraisals in public health. I suggest you start with specific programmes that are about to be axed, but for which there is still potential to save them using your evidence in part. Good point. Okay, there's loads of stuff coming in. Thank you. I really wish we could have had more of an active discussion about this. So it's a bit of a shame that we can't have more of a face-to-face discussion. But thank you so much for all these points coming in. These are going to be really good. They're certainly going to help us when it comes to designing our guidance and designing our next workshop for the public health practitioners, because these are the sorts of things that we will be wanting to include and asking their opinions on. So thank you everyone for all your points. It's really useful. I think I'll pass over to Christina now, and there'll be time at the end for any other questions about the work that we're doing at the end.
Thank you, Sarah. That was great. I'm going to try to share my screen, which when we did the test didn't quite work as well as we'd anticipated. Okay, I think I'm having the same issue, so I'm going to close PowerPoint and open it again and see if that works. Okay, that did the trick, I think. Okay, can you see that? Because
yes, yeah,
yeah, okay. Is that on?
Yeah, that's on
slideshow. Okay,
yeah.
Because I can't see any of you now. So okay. Oh, sorry. I think I'm shared the wrong documents. I'm gonna have I stopped sharing there? Sorry about that. Okay, I'm gonna try that again. Apologies. Okay, is that working now? I can't see you, so if someone can shout out, Sarah. Can you see that? Okay.
So I didn't realize I put myself on mute. Yes, we can see that.
Thank you. Okay, thank you very much for attending our session. What I'm going to talk to you is about the equity component of the workshops that we are conducting in order to develop a guidance document on the incorporation of equity impact aspects in economic evaluations of public health interventions. So we have a number of equity workshop series with the following objective, which is to develop a resource guide for researchers and analysts for measuring and reporting health equity impacts when it comes to conducting economic evaluations of public health programs or interventions. We have a schedule of these workshops. The first workshop took place in March, and we involve members of the public via the SPHR Public Partners Network. And the objective of this workshop was to explore the understandings of equity in public health that the public held, to discuss what equitable and inequitable public health programs might look like, and to explore if, in their view, there was any value in measuring equity when assessing which public health programs should be implemented. There is a second workshop, which is the one that Sarah advertised during her session in July, in which we want to involve public health professionals to also get their views on what they understand as equity in public health, but also to tell us a bit more about the health economic tools that they currently use to measure and report equity, and to explore the needs and the challenges that they face in the quantitative measure and reporting of equity impacts. So I know we don't have any public health professionals here today with us, but actually if you could circulate the date for the workshop, which is the 14th of July, around your networks, that would be great. We are going to circulate it through the FUSE and SPHR networks as well, so you will hear about it. But if you think someone might be interested, it would be great if they could attend. And then there will be a final workshop. This will be with the analysts that are going to be using this guidance to actually finalize the draft document with the information that we have been gathering from the workshops. And it's also information from the literature that will help us put the guide together. And the findings from this final workshop will become the final document. And then there will be, as Penny explained when she was giving an overview of our cross-cutting theme of the work that we're doing, that there will be an overall workshop as well, apart from this, to disseminate all the findings. So I wanted to tell you a little bit more about what happened during our public involvement workshop. We had a number of components to the workshop. First of all, there was a theory component. And as part of that, we prepared a background document on equity concepts, on what does equity mean, what are the implications of equity in public health, and so on, that the participants received a week before, prior to the workshop, just to help them reflect around the subject and that they didn't come cold to the discussions. Those key concepts were also discussed during the workshop, in the first half of the workshop, and that helped us guide the group discussion around a number of case scenarios that I would like to also show you today, if we've got enough time, which hopefully we will. In terms of the theory component, well, we discussed some basic concepts, the differences between quality and equity, how equity in health is linked to the concept of needs or unmet needs, and the difference between horizontal and vertical equity. We also explored how, in order to address those inequities in health, we needed to really have a look at the causes of inequalities. And for that, we use the Labonte et al. Conceptual framework that is used by PHE, outlining the wider determinants of health and health behaviors and how that's related to the physiological impacts and the psychosocial factors that all of them affect health inequalities. So we had quite a nice discussion surrounding those causes of inequalities. And also, in order to address those causes of inequalities, we considered the environment in which public health professionals move, which is one of the scarce resources, and the kind of equity and efficiency trade-offs that also need to be made in choosing public health interventions. Sometimes you have to choose between health maximization as such, or a fair distribution of those health outcomes resulting from a particular program or intervention. And of course, we discussed also the idea, very important, of that of opportunity costs, that when you have limited budgets and you choose a particular intervention, that means that there is another intervention that you don't get to choose. So someone loses out when you make these kind of decisions. So we used that theory component to then jump into some case scenarios. But I'd like to discuss those after I tell you about the findings, because I want to test those scenarios with you shortly. But I want to first walk you through what we actually found from the public as a result of this workshop. To begin with, and when we started discussing equity, we found that the individual's own experiences of health inequalities and access to healthcare and so on really shaped their initial views on equity. They felt that health inequalities were caused by discriminatory behaviors and the fact that they felt excluded from access to public health services, that there was a lack of understanding of the needs of certain underserved populations. This was particularly relevant with issues of neurodiversity and so on. However, as we discussed in detail, the causes of health inequalities and what equity involved, achieving health equity involved, and prioritization, the views did change quite a lot during the workshop. One of the things that there was very much a broad agreement on was that what needed to happen is that the focus needed to be on the causes of the causes. So focusing on individual behaviors and lifestyles were counterproductive, and they were not addressing the real issues. And furthermore, they felt that it led to marginalization of those populations that actually needed those health issues addressed the most. As we investigated the causes of inequalities, we did ask them to say, well, what would you prioritize? You know, would you prioritize improving poverty, or just general access to healthcare, access to public health services, education? There were also issues of power and discrimination. What is it that you would prioritize? And they found it extremely difficult. They found it extremely difficult because they thought they were of a view that they all interacted with each other, that they were interdependent, and that they couldn't really be looked at in isolation. But one thing also that they agreed on is that independently of those causes of inequalities, that those in the lower socioeconomic groups, the poorest in society, those with lowest income, should be prioritized. When we are in a situation in which we're trading off efficiency and equity, there should be priority should be given to those in the lowest socioeconomic groups. However, they also agreed that baseline health also matters. They didn't think it was fair to just look at, socioeconomic groups. If someone in the higher socioeconomic group had really poor health, it would be really unfair to exclude those groups as well. So it was a very rich discussion, and we found it really helpful. There was another finding there. And that the trade-off between efficiency and equity, they thought makes decision-making in public health very tricky. They all recognize that. So how this is useful for us? Well, in terms of developing the resource guide, I think that there's some things that we can't ignore from those findings. The importance that we need to account for the complex causes of inequalities and how these interact with each other. How this translates into a resource guide for the economic evaluation of public health interventions. Well, I mean, in my view, one of the things that need to be included in the workshop would be the importance to develop logic models that outline all these causal pathways that then identify the kind of variables that we're interested in a more econometric kind of way. We could develop causal acyclical graphs to identify confounding variables and so on. So we need to really make sure what is it that we are addressing before we launch into an evaluation. We need to identify all these factors. As well, we need to make sure that there are methods there that prioritize certain populations. If we want to prioritize those least well off, there may be a case for including methods in that guide that allow you to incorporate weights to do that. Also, because health did matter, that the evaluation takes into account the baseline health of the population before you launch into evaluation and so on. And also that since the equity efficiency trade-off is such a real and important and tangible thing in decision-making in public health, that we have the appropriate tools to show that trade-off to help make decisions in public health. Now, I would like to walk you through a couple of the case scenarios, and there will be some polls that you'll have a chance to give your opinion. But let me talk to you about what we wanted them to think about. And we wanted them to imagine that they were decision makers themselves, at least for a little while, and that they had to choose the best public health intervention out of a number of them. So we asked them to imagine that you are in a position to, your objective is to improve respiratory conditions, and you could choose between implementing an anti-smoking educational campaign, or you have funds to create new green spaces, or you can launch a clean air initiative, whereby you reduce emissions from transport, from public transport. You can choose between each of them, and we give them a bit more information, of course. We told them that the budget for each of them was the same, and the target population was also the same. We had a 1 million population, they were urban population, and we were splitting that population in 5 distinct groups. All of the groups were equally large, and they were divided into socioeconomic groups, with group 1 being the most disadvantaged and group 5 being the most advantaged, if you like. So you have all that information, but key to this is that you know from previous studies how many healthy years you will get as a result of each intervention, and how those healthy years will be distributed amongst those groups. So we show them this table. Intervention A, intervention B, and intervention C would each of them yield 100 healthy years throughout. However, for intervention A, you would have the distribution as follows: 20 for group 1, 15 for group 2, 21 for group 3, 21 for group 4, and 23 from group 5. Remember, it goes from least advantage to most advantage. Intervention B, again, has a different distribution. This time, the gains are concentrated in the lowest socioeconomic groups. And for intervention C, you have an equal distribution of health gains. I'm just going to give you a little bit of time so that you have a look at this, because in a minute, I'm going to ask you to choose which intervention you would choose. And for that, I'm going to stop sharing the screen. So just give you a minute there.
I'll just jump in and say, in the polls, intervention B is listed twice. So I presume
is it really?
Yeah, I presume the second intervention B is meant to be intervention C.
If it's listed twice in the polls, yes. It should be A, B, and C.
Yeah, so if everyone's...
So the second B, take that as a C. Yeah. Please. Okay, I'm going... Is it okay if I stop sharing this? Everyone has had a good read at this? Yeah, okay. Right. Okay. So let's have a look at the polls. Okay, so I can see that everyone has chosen intervention B. So everyone thinks that the lowest socioeconomic group in that case should receive the maximum health benefit. I have to tell you that is exactly what the public thought as well. They thought that the gains should really be concentrated in those with lowest socioeconomic advantage, if you like. Right, I'm going to share the screen again because I want to put to you another poll. Okay. Okay. So we gave them then we changed the distribution of health gains very slightly. And with intervention C, in this case, actually increase the overall health gains that you could get from it. And also it changed the way they were distributed. So intervention A and B remained the same, the total health gains and the distribution for each of them. Whereas intervention C, you get 20 more years of health gain, 120, but these are distributed in a way that benefits those with in the highest socioeconomic groups most. So I'd like you to again, and I think this is poll 6, to tell me which intervention you would choose now. Would you change your mind? Okay. You would change your mind. So some of you would change your mind. Actually, this is exactly really what happened with the public as well, was that most of them stuck to the most prioritizing those with lowest socioeconomic means. Some of them thought, well, actually, if you have an intervention that yields more benefits overall, you should still choose that intervention, even if the distribution is not quite as equitable. So this is to me, it's really interesting to see how your views really align with those of the public, which is great. Right, I'll get back to the presentation again. Okay. Now, I don't know if some of you in the chat could perhaps comment whether you can think of another alternative, another distribution that you would have chosen that is not listed there. And Sarah, I can't see the chat, so if you give me a shout if there's any comments, I'll come out of here.
I'll let you know.
Okay. I guess
Lucas said the choice. Oh, can you see it now?
Hang on.
So Luke said the choice between the 3 interventions isn't unanimous. It would be helpful if anyone thought differently to B could let Christina know offline.
Yeah. Yeah, okay. That sounds good. Right.
But yeah, no.
Thank you all, by the way, for voting. I'll just go back to the slideshow. Okay. So this is where it all got a little bit trickier, I thought, for the public. So in this case, we just thought, okay, the decisions that we've taken before, they're quite discrete. You have 3 specific choices, and based on efficiency and the distribution of health gains, you have to choose. But here I wanted to get them to think about a more generic public health approach and what is it that they would actually choose themselves. So we gave them 7 different type of policies, if you like. One of them is one where public health interventions aim to maximize the health across the population without focusing on specific groups. Another one, a public health approach that prioritizes those with worst current health. Another one prioritizing those with worse future health. Another one prioritizing the elderly population. Another one focusing on population most disadvantaged in socioeconomic terms. Another one focusing on those who have the best chance to improve their health. And the last one, it was focusing on the health conditions that are caused by the individual's behavior and lifestyle choices, or perceived to be caused by the individual's behavior and lifestyle choices. So we put that there and we said, what do you think is the most fair approach? If you had to choose one, well, in fact, we asked them to rank them, but unfortunately, we can't do this with this poll system. So in this case, I want you to think, which one do you think is the most fair approach? If you had to choose one as a public health professional, which one would you choose? And I think I've called this poll 7A. Let's see if you can see it there. I'll leave that on the screen so you can still read them.
It's gone live now.
It's gone live. Excellent.
Would you like me to
I think
on the polls?
I can see the polls. Yeah, I'm not sure. There's quite a few people yet to vote. It's extremely mixed, as it was with our public participants. Yeah. Okay, so yeah, I mean, as you can see, it's extremely difficult to make that decision out of context as well. But we just wanted to illustrate how difficult prioritizing in public health really is. And I guess related to that, if you're ready to move on, we have the same scenarios. And in the next poll, which I think is live as well, we're asking you to choose which one is the most unfair of those approaches. Can you all see? Yeah, poll 6B. Yeah, that's what it is in the poll line. Okay.
It's there.
Okay. Again, it's quite mixed. I know the votes are still coming in. Yes, I mean, prioritizing those with the best chance to improve their health seems to be an unfair way to prioritize in public health. Also focusing on the individual's behavior is not the preferred route. So, okay, again, you know, it's a mixed bag. And I mean, that is exactly what we found from the public. Okay, I'm just going to go on to my slideshow again. There's only another slide that it might not really be that relevant to this audience, but I wanted to discuss a number of things. And I guess this is more for public health practitioners. And this is more also what we will be discussing in much more detail at the workshop in July. So we want people to consider their current practice and what additional information or knowledge they would find useful in order to make equity-informed decisions. We want them to tell us about the analytical tools to help make equity impact decisions or evaluations, and whether actually they would find the toolkit or resource guide useful, and whether they consider issues of fairness or equity at all times when developing and implementing public health interventions. I mean, perhaps we do have a few researchers and analysts here, so if you're interested to see, would you find a toolkit and a resource guide that tells you how to incorporate equity considerations into evaluations useful? And I'll stop sharing now, and maybe if you want to put things on the chat or if you have any questions. Yes, Emma. Okay, I'm just gonna go in order from there. Peter, I can see you there. You need to introduce agency in this equation. Yeah, I did see Jean's presentation yesterday, and yes, it did get me thinking, Peter, about how we could actually incorporate that. We need to think, yeah, whether there is actually any kind of tool that we can use, because we're focusing on economic evaluations that allows for agency. But yes, that's definitely, it did get me thinking that is something that we should look at as well. Joanna, yes, thank you, Joanna. I have read Rachel's paper as well. So I'll yes, thank you. Yeah, it was really very interesting, and I'll have another look at it. And I mean, hopefully Rachel might come to the and you yourself to the September workshop and just help us pull it all together and incorporate everything that we're missing. Yes, Emma, you're right. I think you focused on socioeconomic inequalities, and I think that's because that's probably the way kind of equity impacts when they're done. You do have like an index of deprivation or socioeconomic status naturally, but you are right, it can be considered more broadly. There were loads more things that we wanted to cover in the workshop. It was 90 minutes and we went over. I mean, the discussion was amazing. So it'd probably be useful to engage with the public again on this and have a more broad approach. Yes, look, which is why we did include it as an approach that prioritizing population with the best chance to improve their health. I have to say it was not popular with the public, but yeah, that's exactly why we wanted to know what they thought about that. And we just have 5 minutes before the break. Okay, well, actually, I want to share another slide because before you go on your break, I wanted to point you to, well, I don't think I need the slide. I think, Susan, I memorized that to your request, which is to please have a look at the PhD students' presentations during your break, because, they've really not had many chances to showcase their work. And I think you'll also have an opportunity to interact with them later on during the session at noon and ask them questions about their work. But you can watch the video presentations right now whilst you have a break. Thank you, Susan. Please have a look at the work that we're doing. And Emma, I'm just reading your comment. Okay, I'll make a note of that, Emma, because no, I have not I have not connected with Dan or Sarah, so I'll make a note of that.
Thank you. Looks like Penny has on our behalf, so that's fantastic. Thanks, Penny. But yeah, well, we've got 2
great.
so,
Great.
Yeah,
Thank you, Penny.
say thank you to everyone for coming to the workshop. I hope it was useful, and thank you for getting involved with the polls. And yeah, enjoy the rest of the ASM.